Picture this. You are in theater for a 4-hour bowel resection on a 65-year-old woman. Blood pressure is dipping, the surgeon is working deep in the pelvis, and you are wondering, should I hang tranexamic acid?
Or you are in the emergency department at 2 in the morning. A 50-year-old rolls in with an asthma exacerbation, eosinophils through the roof. You reach for the prednisone. But is that still the right move?
Both of those questions got new answers recently. Good morning, it is Monday, August the 3rd. 4 stories today, plus a regulatory update. Let us get into it.
Story 1. Tranexamic acid for major non-cardiac surgery. The Traction trial published in the New England Journal of Medicine in June.
This is the trial you have been waiting for if you give anesthesia. Traction was led by Brett Houston from the University of Manitoba and the Ottawa Hospital. It was a cluster crossover trial. 10 Canadian hospitals, 8,273 patients undergoing major non-cardiac surgery at high risk of bleeding.
60% of those patients were having cancer surgery. That is important because cancer patients are often excluded from bleeding trials due to thrombotic risk. So this is a real-world population.
Hospitals were randomized at 4-week intervals. Either everyone got tranexamic acid intraoperatively or everyone got placebo. Then they switched. This design eliminates the problem of selective administration.
And the headline numbers?
Transfusion rate dropped from 9.8% to 7.4%. That is about 3 fewer transfusions per 100 patients. For every 100 patients treated, 10 units of blood were saved, and critically, venous thromboembolism at 90 days was identical in both groups, 2.1% either way.
This is a big deal for a couple of reasons. First, the VTE safety question has been the main thing holding people back from broader TXA use. Previous trials like POSES-3 suggested TXA reduced bleeding but could not definitively rule out a small increase in thrombotic events. Traction nails it, no signal.
Second, this is cancer surgery inclusive. The fact that 60% of patients were oncologic and TXA was still safe is a major reassurance. Cancer patients are prothrombotic by nature. You needed this data before you could confidently give it to them.
Let me push back. The transfusion reduction is only about 2.5 percentage points. Is that clinically meaningful enough to justify a universal hospital policy?
It is when you scale it. This is not one surgeon deciding to give TXA. This is a hospital-level policy. Across thousands of major surgeries per year, you are talking about hundreds of transfusions avoided. And blood is a scarce resource, especially in rural settings. Each unit carries infection risk, transfusion reactions, and cost. The number needed to treat to prevent one transfusion is about 38.
Let me also connect this to what we already know. POSES-3 showed TXA reduced life-threatening and major bleeding by about a quarter, but it could not definitively rule out a small thrombotic increase. Traction used a different design and a larger sample, and it closes that gap. The mechanism matters too. TXA works by inhibiting plasminogen activation. It stops fibrin from breaking down, so it prevents clot dissolution at the surgical site without systemically activating coagulation. That is why you get local hemostatic benefit without a systemic prothrombotic effect.
Good point. And the cancer subgroup specifically? No excess thrombosis in cancer patients. The effect was consistent across all surgical types. This is the trial to take to your hospital's perioperative committee.
Story 2. A completely different setting. Your clinic. A patient presents with an acute asthma or COPD exacerbation. You are about to write a prednisone script. But what if a single injection of Benralizumab was better?
The ABRA trial. Published in the Lancet Respiratory Medicine, led by Sundar Ramakrishnan and Ian Pavord at Oxford, 158 patients presenting to emergency or urgent care with acute eosinophilic exacerbations of asthma or COPD. Blood eosinophils at least 300.
3 arms. Prednisolone alone, which is the standard of care. Benralizumab alone, or both combined.
The primary outcome was treatment failure over 90 days. In the prednisolone-only group, 74% of patients had a treatment failure. 3/4. That is a staggering number. It tells you how poorly our current standard of care actually works.
And in the Benralizumab arms, pooled together, treatment failure was 45%. The odds ratio was 0.26, a 4-fold reduction in treatment failure. The number needed to treat was 4.
You treat 4 patients with Benralizumab instead of prednisone to prevent 1 treatment failure. That is an extraordinary effect size for a respiratory intervention.
Here is what makes this important for primary care. Prednisone for exacerbations is deeply embedded. Every GP writes for it. But we know the harms: hyperglycemia, bone loss, immune suppression, mood effects. And in this trial, all the hyperglycemia and sinus infection adverse events were in the prednisolone group only, none in the Benralizumab groups.
Now the caveats. This was a phase 2 trial. 158 patients across 2 UK hospitals. The pooled analysis combining Benralizumab alone and Benralizumab plus prednisolone was pre-specified, but the individual arm comparison of Benralizumab alone versus combination showed no difference. So adding prednisolone to Benralizumab did not seem to help.
The Benralizumab dose was 100 milligrams subcutaneously. That is a higher dose than the standard 30 milligram used in maintenance asthma treatment.
Right. But the implications are significant. This is the first trial to show that a biologic can outperform steroids for acute exacerbations. The eosinophilic endotype is common. About half of COPD exacerbations and most severe asthma exacerbations have elevated eosinophils. This is a treatable trait that you can check with a blood test in the emergency department.
For Australian practice, Benralizumab is PBS listed for severe eosinophilic asthma as maintenance therapy, but acute use for exacerbations is not currently funded. The shift here is conceptual. We are moving from one-size-fits-all steroids toward endotype-directed treatment. That is the story to watch.
And the 74% treatment failure rate on prednisolone is worth sitting with for a moment. That is the current standard of care. 3/4 of patients who get prednisolone for an eosinophilic exacerbation fail treatment within 90 days. That is a humbling number. It tells us that what we have been doing for decades is not working as well as we thought.
Pavord has been arguing for years that we need to treat airway disease by inflammatory endotype rather than by diagnostic label. ABRA is the proof of concept. Whether this translates into clinical practice depends on whether the health system can fund acute biologic use. But the principle is clear. Check the eosinophil count before you reach for the steroid script.
Story 3. Stroke. And this one changes what happens in your rural emergency department when a patient arrives outside the traditional thrombolysis window.
The OPTION trial, published in JAMA in April, led by Gaotin Ma and colleagues from 48 centers in China.
566 patients with acute ischemic stroke. But here is the key. These were non-large vessel occlusion strokes, no big clot in the middle cerebral artery, and they presented 4.5 to 24 hours after symptom onset, well outside the standard thrombolysis window.
They all had perfusion imaging showing salvageable brain tissue. Then randomization, intravenous Tenecteplase versus standard medical treatment.
The primary outcome was excellent functional recovery at 90 days, modified Rankin scale of 0 or 1, essentially no disability. In the Tenecteplase group, 43.6% achieved this. In the control group, 34.2%. The number needed to treat was 11.
11 patients treated for one additional excellent outcome. That is a meaningful effect for a condition where we previously had nothing to offer in the late window.
But the safety signal deserves scrutiny. Symptomatic intracranial hemorrhage occurred in 2.8% of the Tenecteplase group and 0% of controls. That is a real risk. 3 in 100 patients had a bleeding complication that could have been catastrophic.
And this was an open-label trial. Clinicians knew which arm the patient was in. That is a limitation, but the outcome assessment was blinded, which mitigates some of the bias.
The broader context. Until now, late window thrombolysis evidence has focused on large vessel occlusions where patients may go on to thrombectomy. OPTION extends the evidence to non-large vessel strokes. These are the smaller strokes, the ones that do not get referred for clot retrieval, the ones you manage in your local hospital.
So, the practical implication for a rural GP anesthetist is this. If a patient arrives 6, 8, 12 hours after stroke onset and imaging shows salvageable tissue, Tenecteplase is now on the table even without a large vessel occlusion, but you need perfusion imaging capability and a stroke protocol to do this safely.
Tenecteplase is already available in Australia. It has largely replaced alteplase in many stroke centers. This trial supports its use in a broader population. The key is imaging-based selection. Do not give it to everyone who walks in late. Use the perfusion scan.
And for rural centers without perfusion imaging, the message is about transfer. If a patient is within the late window and you cannot do advanced imaging, this is a reason to transfer to a comprehensive stroke center where the scan can guide the decision. The worst outcome would be giving thrombolytics blindly to patients who do not have salvageable tissue.
Right. The 3% symptomatic hemorrhage rate is a real number. If you cannot image select, you cannot justify the risk.
Story 4. This one comes up in every prenatal visit. Paracetamol in pregnancy. Is it safe for the baby's brain development?
If you have been following this literature, you know the anxiety. A series of observational studies suggested that paracetamol use in pregnancy might increase the risk of autism, ADHD, and intellectual disability in offspring. Some countries considered restricting it. Many pregnant women were afraid to take it.
Now we have the definitive meta-analysis, published in the Lancet Obstetrics, Gynecology, and Women's Health, led by Francesco D'Antonio and Asthma Khalil. 43 studies in the systematic review, 17 in the meta-analysis.
Here is what makes this study different. It prioritized sibling comparison studies. That is the gold standard for this kind of question, because siblings share genetics and home environment. If one sibling was exposed to paracetamol in utero and another was not, and they have similar neurodevelopmental outcomes, then the drug is unlikely to be the cause.
And the results were clean. In sibling comparison studies, paracetamol exposure was not associated with autism. Odds ratio 0.98. Not associated with ADHD. Odds ratio 0.95. Not associated with intellectual disability. Odds ratio 0.93.
These results held when they restricted to low risk of bias studies. They held when they looked at studies with more than 5 years of follow-up. There was no signal in any sensitivity analysis.
This is one of those moments where the best quality evidence overturns a scare. The earlier observational studies were confounded. Women who take paracetamol in pregnancy are often doing so because they have a fever, an infection, or underlying illness. Those factors, not the paracetamol, are what drive neurodevelopmental risk.
Tell your wife about this one. The clinical message for antenatal care is simple and reassuring. Paracetamol, when used as directed at standard doses for short periods, does not appear to harm the baby's neurodevelopment. Untreated fever and pain in pregnancy carry their own risks. This is not a reason to avoid the safest analgesic we have.
And the sibling design is critical to understanding why this overturned the earlier scare. Conventional observational studies compare women who take paracetamol with women who do not, but those groups differ in systematic ways. Women who take paracetamol are more likely to have infections, fevers, and underlying health conditions. All of those are independently associated with neurodevelopmental outcomes. The sibling comparison controls for shared genetics and home environment, isolating the drug effect, and there is none.
Exactly. The Swedish cohort of 2.5 million births, using sibling comparisons, found the same null result. This is converging evidence from the highest quality designs available. The message is settled.
Quick hits.
The TGA has updated its safety advisory on imported melatonin products. Laboratory testing found one product contained over 400% of the labeled dose. Another contained no melatonin at all. If patients are buying melatonin online or from non-pharmacy sources, warn them. Check for an AOSTR or AOSTL number on the packaging. In Australia, melatonin is prescription only except in specific adult circumstances.
And PBS Watch. the September deletions are starting to appear, mostly brand removals rather than drug delistings. Watch for changes to clopidogrel brands, leucovorin and glyceryl trinitrate patches brands. No major new GP-relevant listings for September, but the pipeline continues to track several drugs through government approval processes.
Recap. Tranexamic acid is safe and effective for major non-cardiac surgery, including cancer surgery, with no thrombotic signal. Benralizumab outperforms prednisone for eosinophilic asthma and COPD exacerbations, with a number needed to treat of 4. Tenecteplase extends the thrombolysis window to 24 hours for non-large vessel strokes when imaging shows salvageable tissue, and paracetamol in pregnancy is safe for neurodevelopment, confirmed by the highest quality evidence available.
See you tomorrow. Stay sharp.